webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2019, all rights reserved. Good afternoon, everyone. My name is Doug Lair. I am a registered respiratory therapist and an associate executive director at the AARC, and welcome to today's presentation, Outcome of Frail Do Not Intubate Subjects with End-Stage Chronic Respiratory Failure and Their Opinion on Non-Invasive Ventilation to Reverse Hypercapnic Coma. That was a mouthful. I'll now hand this over to Mr. Reagan Hickey, who will introduce the sponsor of today's webcast.
Masimo offers a complete portfolio of pneumoline capnography and gas monitoring solutions, both sidestream and mainstream, to meet the challenges of ventilation and gas monitoring across multiple clinical settings. In addition, Masimo also offers a continuous and non-invasive sound-based respiration rate monitoring method, Rainbow Acoustic Monitoring. Capnography-enabled Masimo devices need virtually no warm-up time, provide full accuracy performance in 10 seconds, require no calibration, and benefit from the unique moisture wicking technology of pneumoline sampling lines, helping clinicians streamline workflows.
So before we get started today, let's talk a little bit about what our learning objectives are. And upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implications of the study on patient care. I am pleased to welcome Dr. Shawna Strickland. Dr. Strickland is a registered respiratory therapist, asthma educator, and fellow of the AARC. She is an associate executive director at the AARC as well. I disclose that Dr. Strickland and I are paid employees of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding their availability. Dr. Strickland, good afternoon and welcome to today's program.
Thank you, Doug. I am very excited to be on this side of the microphone for this webcast. I really enjoy this topic specifically. My own family's experiences and my past academic experiences led to my interest in the use of non-invasive ventilation at the end of life. And depending on where you work, you might have some issues with whether or not to utilize non-invasive ventilation in various populations. I tend to talk about this topic in the context of medical ethics, but the study we're going to talk about today provides us with some clinical outcomes to go along with our ethical discussion and provides us a nice foundation for a well-rounded discussion with our colleagues and patients. So typically, we equate non-invasive ventilation with avoiding intubation or bridging a patient to recovery from their original condition. Just to be clear, we're talking about non-invasive ventilation with some sort of mask interface, but the patient is still spontaneously breathing. The study we're going to talk about today explored the use of non-invasive ventilation with end-stage chronic pulmonary disease patients suffering from acute hypercapnic respiratory failure, but those patients also had do not intubate orders. So to be clear, we're talking about patients who have end-stage COPD, have an acute condition, that acute on chronic hypercapnic condition, but they have also already identified that they did not want to be intubated. So it's very important to make sure that we have the right construct in our mind as we go forward. So the focus of the study was not just the clinical outcome of the patient, but also their point of view on using non-invasive, even though their chronic condition could not be cured. I'm going to assume that everyone who's on the call today has experience with non-invasive ventilation. We know that we can use our inspiratory positive airway pressure and our expiratory positive airway pressure to support the patient's spontaneous tidal volume and expiratory pressure, respectively. We know that using non-invasive can offload some of the work of the ventilatory muscles and take some of the burden off of the patient. If you're looking for a really good review of these physiologic effects of NIV, check out the June 2019 issue of Respiratory Care. Dr. McIntyre has an excellent review of those physiologic effects and how each effect is produced. And if there are some students joining us today, I hope there are, I would absolutely suggest that you read Dr. McIntyre's article. Also, the entire June 2019 issue is dedicated to non-invasive respiratory support, so I highly suggest you check out the whole issue. Anyway, several pieces of literature that I'll discuss today come from that issue. So the last bullet on the prior slide focused on non-invasive resetting the ventilatory control system. How does that work? As Dr. McIntyre reminds us, the tidal volume, the respiratory rate, and the I/E ratio are controlled by the ventilatory control center, which is located in the brainstem. On this slide, we see the impact of the improvement of gas exchange, starting in the upper left corner, the unloading of ventilatory muscles, starting in the upper right corner, and reducing dyspnea near the middle right of the slide. In the middle of the slide, we see how these factors come together to influence the pattern generator in the brainstem. Now that we remember how non-invasive works, when should we use it? Hill and colleagues in that June 2019 issue of Respiratory Care reminds us where the evidence is strongest in regard to non-invasive ventilation. Note that the first item under the strong indication category on this slide, that's the box with the blue in it, or the box outlined in blue, is acute or acute on chronic hypercapnic respiratory failure due to COPD. This is the part that's relevant to today's discussion. Note, though, that the evidence is weak, if you go to the bottom of the slide, for the same type of a condition, acute or acute on chronic hypercapnic respiratory failure, for other chronic pulmonary diseases such as asthma, cystic fibrosis, or obesity hypoventilation. So what happens when the acute event is not the primary incurable disease? This is a very common phenomenon. Pneumonia is frequently the cause of death for long-term illnesses like ALS and post-stroke patients. Can we cure pneumonia? Usually. The patient is, at that time, in a new kind of pain that we can alleviate. Some argue that we should alleviate this disease process, the pneumonia, the acute condition, if it is possible. Now we have to remember that there is, of course, an underlying condition that is not curable, but we've got now two things to deal with. We have the non-curable chronic issue, and then we also have the acute issue, such as pneumonia. Now, shifting gears a little bit, non-invasive became a popular intervention for a reason. Comparatively, It's relatively simple. The patient does not usually require sedation, and the mask can be tailored to the patient's face. Although if you are a seasoned respiratory therapist, like myself, you'll remember the time when we had non-invasive masks that were one size fits nobody, and they were hard plastic and not comfortable. But we've come a long way since then, so we have many different options to fit the mask to the patient's face. So if it's not that difficult and it's non-invasive, and we can simply improve the comfort of the patient without intubation, without sedation, without major interventions, do we not have a duty to do so? It's non-invasive, which means it's easily applied and removed. We can blow off a little CO2, force a little diffusion of oxygen. Patient can take the mask off and talk to their family. They can finalize end-of-life documents or just simply recover from an acute event and go back to your previous quality of life at home. So there are many positives. There are many reasons why we should be using the non-invasive intervention at the end of life. But not everyone agrees with those arguments. So let's look at it from a different perspective. All convenience aside, the machine still provides positive pressure at end expiration, during inhalation, and a rate or inspiratory time can be set. Supplemental oxygen can be delivered. This is still a form of life support in context of our end-of-life situation. Another argument is that not all of our end-of-life patients will be candidates for this intervention. If our patient is an end-stage COPD patient with serious CO2 narcosis, they may not be alert enough. They may be overly somnolent. And while the non-invasive intervention may blow off some CO2 to help reverse this, can they still protect their airway from aspiration? And then, of course, we have the issue with whether or not the patient's belly is expanded with the air that might go down the esophagus instead of the trachea, and that might help promote maybe some vomitus, which lends itself more to aspiration. So we see that cycle move along. But how about the COPD? How about the end-of-life CF patient? Lots of secretions could be a major problem with non-invasive. Also, all of the indications aside, this is a temporary relief. This is not going to reverse the chronic condition, right? This is a temporary relief of shortness of breath, temporarily blows off the CO2. It may temporarily restore coherence in the patient, and that can be misleading to the family. The healthcare team knows that as long as the patient's receiving the NIV, they may be well oxygenated, well ventilated, and they may be able to talk to their family. The family, as well as the patient perhaps, may see only the benefit and not realize that this isn't a reversal of the disease process, but merely some respite from the side effects of that advanced stage disease. And then the system causes discomfort. We are all well aware of that. Skin pressure ulcers, gas flowing into the eyes if the masks aren't fit correctly, abdominal distensions. These are not exactly minor complications. So we have a good set of arguments for using non-invasive at the end of life, but then we also have some very logical arguments for why this is a difficult concept to get behind at this point in time. So what I want to do for the next few minutes is talk more about the patient population for the study, those COPD patients, those end-stage COPD patients with an acute on chronic exacerbation. So Fernandez and colleagues in a 2007 study looked at efficacy of non-invasive ventilation in do not intubate patients. They discovered that the non-invasive support in these patients who also had DNI orders may buy us some time, so to say, or even help the patients survive their ICU or their hospital stay, but they found that it did not offer much in the way of medium-term survival. But if the patient already has established treatment-limited decisions, meaning they've already identified, I don't want intubation, I don't want CPR, and so on and so forth, simply surviving hospitalization and returning to their home may be that desired outcome of that patient. This study by Fernandez demonstrates that this could be a viable reason for initiating non-invasive, simply helping the patient get back to the home so that they can have their end of life outside of the hospital. In 2018, Wilson and colleagues performed a systematic review and meta-analysis of the studies that assessed the outcomes of non-invasive for acute respiratory failure in patients with do not intubate or comfort measure only orders. They wanted to know about the survival, quality of life, and treatment tolerance of patients with do not intubate orders who also received non-invasive ventilation for acute respiratory failure. They also looked at dyspnea control, opioid requirements, tolerance of treatment, tolerance of that non-invasive ventilation, and survival in patients who had comfort measures only orders who also received non-invasive. So you can see the framework of their study here on this slide. The meta-analysis discovered that non-invasive was generally well tolerated by the patients with do not intubate orders, and found something, and similarly to that Fernandez study, they found that do not intubate patients with COPD had better long-term survival than those without COPD. So Wilson and colleagues, their conclusion was that the analysis showed that non-invasive ventilation achieves survival with an acceptable quality of life in a significant proportion of patients with do not intubate orders, in contrast to some experts who have claimed that non-invasive ventilation in this patient population simply prolongs the dying process. In another study, this one was published in 2016 by Carlucci and colleagues, they conducted 55 patient interviews with 3 different sealing options. So what did the patients want? They asked them if they wished to be intubated, if they wished to receive non-invasive ventilation, or if they just wanted to receive comfort measures like oxygen and pain control. And a higher percentage of the interviewees chose non-invasive, as you can see on this slide, over the other option. What was interesting was who chose what option. So I've got some colored arrows here to show you where the most likely person would be to identify that that particular intervention. So those who chose non-invasive were more likely to be currently receiving non-invasive, so they have experience with it, or they recently experienced a family death. Those people were much more likely to select non-invasive than the other options. Those who chose to be intubated were those who had experienced intubation at least once in their life. So that makes sense. If I've been intubated and I know what that experience is all about, and I've survived that intubation experience, it might not be as scary to me as someone who has never experienced the intubation and mechanical ventilation process. And those who chose comfort measures only were more likely to have had a previous discussion with a pulmonologist about the course of their disease. So it's interesting to me that the people who have had discussions with their healthcare team chose the comfort measures only. And so I think that leads us down this path of how important it is for our patients to have very frank and, yes, difficult conversations with with their healthcare team so that we can help them select what they need in those final moments. So Davies, in that 2019 respiratory care issue, explored the research focused on the use of non-invasive ventilation in palliative care. And so on this list of different studies, we've already discussed the Fernandez study. The other studies support what we've already discussed during our brief time today already. COPD patients have a better prognosis than non-COPD. Non-invasive appears to be effective in helping the patient overcome that acute on chronic condition, and non-invasive can be a dignified method of support while returning the end-stage patient to their prior quality of life. And that's the big thing, right? We have to remember that we're not going to cure our patient's COPD or end-stage pulmonary disease, but we can help them get as close to that prior quality of life as possible. A common question about non-invasive at the end of life focuses on that quality of life. So going back to one of our previous arguments for using non-invasive at the end of life was that bridge to discharge to home, that we thought that that was a viable option for our patients with end-stage lung disease. Many healthcare providers have stated that non-invasive at the end of life is a futile intervention, meaning that no matter what we do, we will not appreciably change the course of the disease process or avoid death. In the case of using non-invasive as a rescue to sustain to discharge, the disease process isn't changing, but we are facilitating discharge to a more comfortable space where the patient may be able to live out the remainder of those days. Azule and colleagues, represented here on this slide, conducted a large multi-center study comparing the effect of non-invasive on quality of life in patients with a do not intubate order to the effect of NIV on quality of life in patients who did not have treatment limiting decisions. So again, is non-invasive overly burdensome at the end of life? In this table, they demonstrate that the difference in the assessment of quality of life with that SF-36 questionnaire was not statistically significant, nor was it statistically different with regards to the anxiety and depression experienced for both the patients and their relatives. So far, we don't see anything that says that the burden outweighs the benefit. So let's focus on the study at hand. None of the authors of the study disclosed any conflicts of interest. The study was conducted in France, where the local ethics committee approved the study. And they also signed informed consent from the subjects or the subject's next of kin. I don't see anything in the study that gives me heartburn about ethics violations or conflicts. This study was conducted in 3 different hospitals in France, and this was an observational study, a prospective observational study. And observational studies have inherent limitations in terms of susceptibility to bias and confounding. However, they do reflect daily clinical practice more closely than randomized control trials, so that's good. These types of studies can provide clinically relevant information, though, again, bias and confounding should be measured. This was a prospective study, so the researchers followed their participants for a 2-year period in 2 intensive care units and 2 respiratory intermediate units in 3 tertiary care hospitals in France. So to be included, they had to have a DNI order, and they had to have non-invasive ventilation. Here are the 2 groups. So there were 43 individuals diagnosed with hypercapnic coma in the study group, and they were compared to 43 individuals diagnosed with acute respiratory failure but not comatose in the control group. So you can see on this slide the difference in the criteria between the two cohorts. Both had signs of acute respiratory failure, but the study group's blood gases were considerably worse than the control group. You can see that on this slide. In addition, the coma scale score in the study group was higher than the control group. And for those who might not have used Hoover's sign in the past, that is where you see the inward movement of the lower rib cage during inspiration instead of outward, like it typically does. That implies that the diaphragm is flat but still functional, and that's pretty common in COPD. So they also used the Kelly and Matthay score, which is used to assess the level of consciousness in critically ill patients requiring invasive mechanical ventilation. Now, we know that our patients here in this study were not invasively ventilated, but we use the scale. The Kelly and Matthay scale ranges from 1 to 6. Grade 1 is a patient who is very alert and follows complex 3-step commands, and then the patient's cognition drops from there until we get to 6, which is comatose with brainstem dysfunction. So we see that the control group had a Matthay score, Kelly and Matthay score of 4 or less, which indicates a stuporous or a patient who can intermittently follow simple commands, and then or better or more cognizant. And then the greater than 5 would be a comatose patient. And so the researchers, of course, obtained consent from the patient and or family. After that informed consent was obtained, they initiated non-invasive ventilation with a full face mask interface and the BiPAP Vision non-invasive ventilator. The ordering physician decided the NIV settings, and the patient was assessed for response. If the patient was not tolerating NIV well, they were removed from the machine, and then compassionate care with terminal sedation was instituted, and then the family remained with that patient until they expired. So I think one of the takeaways from this particular study is that they were very respectful toward the patient and the patient's end-of-life process, and the need for the family to be treated, patient and family, to be treated with respect. Since the researchers were trying to assess the subject's outcomes with NIV, as well as their perspective on receiving NIV as an intervention, they measured a great deal of variables, which are listed on this slide. In addition to the basic age, gender, and weight, they also asked about smoking history, underlying disease process, and recorded the duration and settings for the non-invasive used in the emergency department. They identified that the majority of the patients, over 50% in each cohort, were diagnosed with COPD or interstitial lung disease, and the majority of the causes of acute respiratory failure were due to exacerbation of that chronic disease or pneumonia. So again, the researchers were looking at this experience from many lenses and tried to get a complete picture of the patient's physical health. They used the MRC to grade the effective breathlessness on daily activities as perceived by the subject. They also used the Charlson Comorbidity Index, which classifies comorbid conditions that might alter the risk of mortality. The higher the score, the higher the predicted risk of death. Diseases like CHF or COPD are scored as a 1, and metastatic tumors are scored as a 6. The researchers used the clinical frailty score, which was developed to provide clinicians with an easily applicable tool to stratify older adults according to level of vulnerability. The scale is numerical, with 1 equaling a very fit individual and 9 indicating a terminally ill individual. They used the NAS chronic health status score, which describes baseline health. They used the SAPS-2 score, which is used to calculate the probability of hospital mortality. They use the STOFA score to describe the degree of organ dysfunction in critically ill patients, with higher scores indicating failure. And in the follow-up phone interviews, they use the VQ11, a health-related quality of life instrument, conceptually more focused on the functional, psychological, and social impact of COPD. So lots of tools to make sure that we have that 360 view of what's going on at that point in time. So because they used so many different types of data points with different instruments, different statistical tests were necessary. To test normality, the Kolmogorov-Smirnov test was used. Basically, this test determines if two data sets differ significantly. Values were compared with when it was normally distributed by the student's t-test and when not normally distributed by the Mann-Whitney. Fisher's exact test is a way to test the association between two categorical variables when you have small sizes. The chi-square is used when you have large sizes. The Cox regression model is a model used for investigating the association between survival time of patients and one or more predictor variables. They use the Schoenfeld test to test the independence between residuals and time. Basically, this is used to test the proportional hazard assumption in that Cox model we just talked about. And finally, they used the Kaplan-Meier curve to measure the fraction of patients living for a certain amount of time after the intervention, in this case, during that 6-month study period. Table 1 is a really long table in the article, which is uploaded for your ease of review. So I've broken it into small pieces so that we can look at what's going on, and you can still see the numbers on the screen. Here, we have the admission assessment information. No statistically significant difference in any of the demographic information or scales, except for the SAPS-2 score, which is logical because the study group were diagnosed as comatose upon admission and the control group was not. Note that the comorbidity index score, the dyspnea score, and the frailty score were all relatively the same for both cohorts. Here's another segment of Table 1. Here we have the clinical assessment of the respiratory system. The pH, the PaCO2, and the bicarb are statistically different, but again, one group was diagnosed comatose upon admission and the other was not, and so we saw that earlier with the demographics of each group. Note also that the medium IPAP on the comatose group was a little higher than the control group, but again, that's logical. The blood gas results indicate that higher support would be necessary. And here we have Table 2, which shows us the outcome measures by group. So the comatose group, as you can see in that first line, stayed on NIV a bit longer. I don't think that's much of a stretch for any of us. The other outcomes were pretty similar for both groups, including hospital and ICU length of stay and in-hospital mortality. And Figure 1 shows us the 6-month survival rate. This is that Kaplan-Meier scale. Note that the p-value in this case is 0.44, indicating that the difference between survival rates of the comatose group and the control group were not statistically significant. So far, nothing we've seen in this study, nothing we've seen with the outcomes of this study, indicate that NIV is an inappropriate intervention in the comatose group. Table 3 gives us the results of the scores for the assessment tools we discussed earlier. Note that the only statistically significant result in the univariate analysis was from the Charleston comorbidity score. In the multivariate analysis, we see that age was a predictor of 6-month mortality, as well as the presence of pneumonia and the NOS index, which described the baseline health status. And we briefly talked about that VQ11 score. That's the health-related quality of life instrument that was focused on the functional, psychological, and social impact of COPD. A score of 22 or higher indicates poor quality of life. So with a p-value of 0.056, the researchers identified no statistical significant difference in the median levels between the two groups. So what does all of this mean? In a nutshell, where are we? Well, in the discussion section of this paper, and if you haven't read it yet, I highly suggest that you read it. Very well done. The authors identified that non-invasive is usually successful in frail subjects with acute on chronic respiratory failure and who had a do not intubate order, even in the presence of hypercapnic coma. Other studies support the use of non-invasive ventilation at the end of life. Rochwork in the 2017 RRT-ACCS clinical practice guideline for non-invasive ventilation for patients with acute respiratory failure suggested offering non-invasive ventilation to dyspneic patients for palliation in terminal cancer. In a 2008 publication, CNF assessed the attitudes of not only pulmonologists, but also respiratory therapists toward the use of NIV at the end of life. I love this study. What they found was, in that CNF study, 87% of respiratory therapists and 62% of physicians indicated that non-invasive ventilation should be included at the end of life. That always interests me because clearly the respiratory therapist spends more time with the patient. That's kind of our job. And so we do have that more intense interaction with the patient that would make us think, yes, we do need to talk about this more often. We think that this should be something we add to the discussion prior to the event happening versus waiting until end of life hits. What they also found was that 42% of physicians and 32% of respiratory therapists agree that non-invasive can provide additive effects of analgesics for relief of dyspnea. Now, that study didn't focus solely on COPD patients, but I found it interesting that there was a 10% difference between what the physician perceived as beneficial and what the respiratory therapist perceived as beneficial for the patients. And so if you'll indulge me for just a quick moment with a personal story, my great aunt passed away a couple of years ago from COPD, and she was admitted into the emergency department. She had stage 4 COPD, oxygen dependent, CO2 narcosis, and my mother called me because they were in the emergency department and they were talking about intubation. And my aunt had been very, very, very vocal throughout her disease process that she did not want to be intubated and mechanically ventilated. And so I asked my mother, have they contacted the respiratory therapist in the hospital yet? And she did not think they had. So I said, please have them contact the respiratory therapist so they can come to the emergency department and assess my aunt. And so they did. They called the respiratory therapist. And all I know is that her name is Vicki, and she is somewhere in Southern Illinois, and she is my respiratory therapist hero. She came to the emergency department. She worked with my aunt. She put her on non-invasive ventilation to help her get over her exacerbation there in that moment. And it worked very well. She followed my great aunt very well. Her relief, the next respiratory therapist that came in, again, great work. And they worked with my aunt for about 36 hours on non-invasive ventilation until she was at a point where she could make her own decision. Eventually, my aunt decided she wanted to receive comfort care only, but that intervention of non-invasive at that point in her life was an extreme blessing for not only my great aunt, while she was able to maintain the autonomy over her treatment decisions, but also my family, so that they could understand exactly what my aunt wanted, so that they could help make sure that her wishes were followed as her life progressed. So as always, the authors have provided us some recommendation for future research to inform our practices. And though these participants demonstrated that non-invasive can be successful in this very specific population, remember we had patients who were end-stage COPD with an acute on chronic issue, excuse me, there will always be some patients who do not respond as anticipated. Therefore, some research into the predictors of poor response would be helpful. On the flip side, it would be good to have some predictors of success so we don't inappropriately or prematurely remove non-invasive from a patient who is actually doing quite well or where success is down the line. The researchers also caution us to discuss each situation with each patient and family, understanding that the perception of NIV as either a burden or a benefit may be affected by culture, religion, past experiences, caregiver opinion, reimbursement status, insurance status, and other factors. And the authors also acknowledge the study limitations. There may be some selection bias, but honestly, a randomized control trial for this type of study is just not ethical. Allocating what could be life-saving intervention on a randomized basis is just not appropriate. Also, the researchers lost several patients to follow-up due to delirium, dementia, hearing loss, and extreme frailty. There was no way for the researchers to determine whether or not those patients would like to receive non-invasive again. Non-invasive was applied with the same type of ventilator, interface, circuit, and protocol. Would other protocols, other ventilators, other masks or interfaces produce the same results? We don't know. And, as with many interventions, the outcomes may depend on the expertise and training of the staff. The authors mentioned that their staff were well trained and they used adequate patient monitoring. Remove or alter one of these variables and the outcomes may change. John Davies from Duke wrote the editorial accompanying the article. He points out that the argument that NIV would be burdensome and that it would add to the patient's discomfort would be valid in a heterogeneous population, but using NIV in this specific population or COPD patients experiencing acute on chronic respiratory failure may have a decent chance of surviving an acute hypercarbic event. In this patient population, there may be some component of reversibility in which non-invasive will be beneficial. He also points out that the guidelines from the British Thoracic Society and Intensive Care Society state that the severe acidosis should not preclude a trial of NIV for an exacerbation of COPD. So what's the take-home point? Well, don't be so quick to dismiss non-invasive as a viable option for your end-of-life patients. Will it change the trajectory of their end-stage pulmonary disease? Probably not. May it help with an acute on chronic episode? Maybe. The point is that attempting a trial of NIV with an assessment of how it improves or doesn't improve the patient's clinical condition may return the patient to their prior quality of life. As recommended by Mr. Davies, clear endpoints must be established so as not to prolong or delay the dying process. Here's my list of references, and I am happy to take any questions.
Well, Shawna, I'll give you a bit of a respite, get a sip of water. I know what it's like with those scratchy throats, especially in the middle of a presentation. Excellent delivery of this content here. And from my perspective, I thought your own personal story really put this into perspective. And while the NIV is not going to address the long-term prognosis, it was in your aunt's situation able to get her through the exacerbation to where she was able to make those autonomous decisions on our own regarding our care, and I think that's something that we don't want to let respiratory therapists lose sight of. Quick question for you. Had one question that comes in, and why is it that you think that some RTs are hesitant to recommend NIV for patients at end of life? Is it because they're just not comfortable having the conversation? What do you think might be driving that decision not to recommend NIV at end of life?
Well, I think you've touched a little bit on it, Doug. I think that many of us are uncomfortable with those end-of-life decisions, or I'm sorry, not decisions, discussions rather. It's not a training that we all undergo on a regular basis. So when you're not exposed to those conversations on a regular basis, you don't feel competent. It's like motivational interviewing with tobacco cessation patients, right? If you don't do it all the time, you don't feel overly comfortable having those conversations. Some of us might simply feel that it's not our place, quote unquote, our place to have those conversations. The physician should be having that conversation. I think that we simply shy away from things that make us uncomfortable. So the overall issue, though, I think, is multidisciplinary discussions with the patient's family. Clearly, the physician has a skill set and a knowledge base that helps the patient and their family make that decision. But incorporating your own experience with the technical side and all of the various patients that you have worked with over time into that conversation can be very beneficial. I recall an end-of-life discussion when I was an ethics consultant with the pulmonologist, and the pulmonologist pulled myself, the nurse, and the patient's spouse into a room, and it was an amazing conversation. It wasn't a dictate from the physician. It was a conversation between the patient, the family, and the healthcare staff on the realistic expectations of doing nothing, providing non-invasive, or intubating and providing mechanical ventilation. And in that case, ultimately, the patient had decided that he wanted to use non-invasive ventilation until his daughter could get there from California. And so the respiratory therapist instituted non-invasive ventilation. The patient survived for another 36 hours waiting for the daughter to get to the Midwest from California. They said their goodbyes, they removed the non-invasive ventilation, and the patient passed. So in that situation, I think that adding the respiratory therapist's voice to the conversation enhanced what the patient could, and enhanced their ability to make a good informed decision.
That was an incredible response. We have a question here from Teresa, and she says, at what point would we respond to an order from a physician via family member to remove BiPAP or suggest removal of BiPAP or NIV, and when to discuss this with the family member? So, if the patient is on NIV and not responding appropriately, do you have any advice on at what point or what data set or what blood gas levels we should be looking at to make those recommendations?
That's a really great question. I don't know that I have a really great answer for it, though. I think myself personally, I would probably look more at, the patient is unresponsive. I think this is where I'm going to scoot back a little bit on slides. I'm going to scoot back to that future research slide that the authors provided. I think this is where we could really use those predictors of poor response, because if the patient is unresponsive, if the CO2 is at COPD normal, as I see in the question here, I would wonder what the desired outcome was for initiating non-invasive ventilation, because if returning to responsiveness is that desired outcome, clearly that's not being achieved in this situation. So I would reinvestigate what is our measure of success here, what are we trying to achieve, and that would be the discussion that I would have with the physician. I hope that answers your question, Teresa.
So we have another question here that says, isn't it unethical to provide NIV at end of life, especially if it's against the patient's wishes, and doesn't it violate DNAR or DNI?
That's a really great question. The ethical principles that we typically go for are the top four: autonomy, justice, non-maleficence, and beneficence. And so when we talk about violating ethics or an ethically unsupported action, we have to ask, A, what did the patient want? If they've already signed a DNAR or a DNI order, or the physician's already made that in conjunction with family, rather, if that's already occurred, technically, using non-invasive ventilation does not violate a DNI order. That's literally just putting the tube down. If we're talking about violating the DNAR, what they're saying is, if my heart stops beating, if I stop breathing, I do not want these interventions. So technically, we're not really violating those orders. Ethically, though, are we prolonging that dying process? And that's where the evaluation of the desired outcomes need to come into play. Are we trying to get this patient to a spot where they can say goodbye, where they can maybe transition to home so that they can be in their home when they pass? We know we're not going to reverse the dying process. That's not happening. But can we provide a little extra time? And if that desired outcome is achieved with non-invasive, then I would argue that no, it's not an unethical act. I do know that I've been a respiratory therapist for a long time, and I've worked a lot of different places, and I've worked with a lot of different respiratory therapists, most of them exceptional respiratory therapists, but I have overheard respiratory therapists stating things like non-invasive on a DNI or a DNAR patient is a waste of time. And I think that we forget the purpose. The purpose of using non-invasive is not to make them well enough to reverse the COPD process, go home and go back to work, or go out to the ball field with the grandkids or whatever. The point is to improve their quality of life as much as possible. And if we can keep a patient comfortable at end of life and help them transition to that next stage in a respectful and dignified fashion, I would argue that that's our duty. If it means that I have to spend an extra 15 minutes checking in on a patient, making sure the mask fits well, making sure that they're tolerating the intervention well, then I'll spend that extra 15 minutes doing that work. Again, though, not every patient that we try this intervention on will benefit. And that's part of the job too, right? Reassessing, making sure that what we're doing is continuing to be effective. If it's not, then we need to reevaluate our desired outcomes and come to a new decision on how we're going to achieve those, or even if we can achieve those.
So I think we've got enough time for just a couple more questions. And I know that you're not a physician, even though we all refer to you as Dr. Strickland, at least a medical doctor anyways. What do you, in your experiences using NIV with patients at end of life, do you have any recommendations on what sedation might be best suited for patients with that type of therapy?
Well, there are some sedatives that are there are some sedatives that work better than others. You know, clearly we want to make sure that whatever we're using is not going to affect the respiratory center so that we don't cause respiratory depression. I do know that there were a couple of articles in that June 2019 Respiratory Care Journal that did talk about sedation and appropriateness of sedation. So I'm going to refer the question back to that June 19 issue of Respiratory Care that has some discussion on sedatives and appropriateness and what the literature says about that.
Fair enough. And the last question today before we let you go. So all of our audience today, or the vast majority, are going to be our respiratory therapists. Hopefully we have a few students with us today. But what would be your advice on applying the results of this study, applying the findings of what you presented today into everyday practice for respiratory therapists? Because I think ultimately that's what we're all looking for. Give us the takeaway. How can we implement what we learned today from Dr. Strickland into our everyday practice?
I would say make sure you keep an open mind. It's hard to do, especially as we go on in our clinical day and we have more and more experiences and we gather more and more data from the patients that we interact with. It's easy for us to say the patient has a DNAR, the patient has a DNI, therefore I give no mechanical ventilation at all. And it's difficult to question our assumptions and critically think through that situation and say, okay, hold on. I know the patient has end-stage COPD. I know the patient has end-stage interstitial lung disease. I know the patient cannot be cured. I'm not going to take away this disease process with an antibiotic. That's not going to happen. Does that mean that I can't provide at least temporary relief from their suffering? Keep an open mind. Evaluate the patient. Might they be a candidate for a trial of an IV? Attempt the NIV. If it doesn't work, it doesn't work. Evaluate them, assess them, and move on. But if it does work, then you've provided something that very few people, very few professions can provide to their constituents. You provided the gift of time for that patient. Time to recover back to their prior quality of life, time to interact with their family, time to say that last goodbye if that's where they are in their journey. So I would challenge everyone to keep an open mind, assess your patients based on where they are with their disease process and their journey, instead of just assuming that because they already have those advanced statements, that advanced directives, that they wouldn't be able to benefit from that intervention.
Great insight. Shawna, it is always a pleasure hearing you present. I always learn something from you, and I would guess anybody in the audience who's heard you present before feels the same. Thank you so much for joining us today, and for all of you, thank you for joining us this afternoon as well with Dr. Strickland. The AARC is pleased to partner with the Smoking Cessation Leadership Center on a nicotine cessation webinar presented by Gabrielle Davis on September 25th. Gabby is an expert in the area. You don't want to miss that. The Respiratory Care JournalCast returns on October 18th with the October Editor's Choice presented by Tyler Weiss. And of course, if you haven't already registered for AARC Congress 2019 in New Orleans, we encourage you to do so. It will be a phenomenal show in the Big Easy. As always, thank you for joining us, and have a great day, everyone. Thank you.
Thank you again, everyone, for joining today, and a big thank you once again to Dr. Strickland for a great presentation. So at this time, if you're a group participant, you can have your group leaders submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. And this concludes today's presentation. So to submit for credit, you can click on the Credit Submission tab, and once finished, you can exit out of the browser. If you do not see this, you can refresh your browser and then select the tab once more. Thank you again, everyone, for joining, and we hope that you have a great afternoon.